Pediatric endocrinologist at South Central Foundation, where she's on a mission to make hormones and diabetes management a little less mysterious and a lot less intimidating. Before landing in Alaska, she served on the clinical faculty at Seattle Children's Hospital. A proud Harvard alumna, she went on to earn her medical degree from the University of San Diego in 2016, because apparently she didn't think Harvard gave her enough homework. Diagnosed with type 1 diabetes as a child, she brings both medical expertise and firsthand experience to her patients. She's basically lived the textbook, so you don't have to. Her passion for child health equity led her to complete a specialized fellowship in the field because she believes every kid deserves a fair shot at thriving, regardless of their zip code or A1C. She is a proud member of the, how do you say this? Ahashman Nation. When she's not wrangling glucose charts or tricky thyroids, you can find her traveling, hiking, or keeping up with her sassy 13-year-old daughter, who makes sure mom never forgets what real attitude looks like.
Thank you, everyone. And it's been like really awesome getting to see a lot of familiar faces from last year, and then a bunch of new faces or faces that I only knew for about 5 years via telephone and or email. So thanks for having me. I was really excited when Anne sent me an email earlier in the year about presenting. Okay. And I thought, well, this is perfect because I have never used inhaled insulin before. Right. And kind of literally love to live the textbook. So I have type 1. I've tried like every pump except one. I won't name it. All the insulins, right? Lumjev, Fias, in a pump, in the injections. I've added some SGLT2 inhibitors. Thank you, Jardiance. I've done some low dose GLP-1s. I've done some low dose tirzepatide. So I was like, this is perfect. I'm going to go to my endocrinologist and I'm going to feel like I need some inhaled insulin. So I was really excited. I even moved up my appointment a month in advance because I was like, she's going to need some time to do the PA and do some things. Okay. So I show up a month early and I said, like, I was telling my nurse, Jess, I'm like, I'm going to record it, right? Our little adventure on doing inhalable insulin. She has type 1. I'm like, this is going to be so much fun. And so I show up and I'm talking to her and she knows, right? Because she's the one who's prescribed all these other things for me to be like, oh, I'm game, Jen. And I was like, so tell me, Dr. Earhart, I was like, what do you think about inhalable insulin? And she goes, Jen, she's like, you're on a closed loop pump. And I was like, she's like, there's Lumjev in it. You're on the things. Like, I don't think it's going to bring you much value. And I said, but I have this presentation. And I was really hoping to bring some real world experience. And she's like, okay, well, you should have come to me sooner. This is what she said. She goes, you need to be able to do your PFTs, and then we need to do a PA to get it approved. And sadly, I didn't get to use any inhalable insulin. It was really sad, but I will show you along the way where we would have had really fun videos. Okay. So, objectives for this talk. How do I move my, okay, there we go. 3 big things, right? I want you guys to be able to kind of compare the different pharmacological profiles of inhaled insulin versus other injectable sub-Q rapid acting insulins. Okay, because that's important because it's going to tell you a little bit about how it can be used for your patients. Okay, and also be able to identify kind of those appropriate candidates, knowing the contraindications are going to be big. And also just to be able to evaluate the clinical evidence, right? Some of the studies that have come out about this, or the studies that are about to come out on this, and some of those practical real world applications, especially being here in Alaska. Okay. Okay. So what is, you pronounce it Afrezza, okay? I'll just probably call it inhaled insulin because it's easier for me. But it's this ultra rapid acting inhaled insulin that's in powdered form. Okay. And it's made up of two major components. Okay. One piece is your insulin, and the other piece is what's called like a technosphere particle. And what that particle is, it actually, I'm really simple. So I think of it as like a delivery truck. So it's able to move down deep, deep, deep into the lungs, take that insulin, which then allows that insulin to be absorbed, much like THC that we smoke, through our lungs and more rapidly enter into the bloodstream. Okay. So it really most closely kind of mimics this first phase insulin response more closely than sub-Q kind of analogs. And it's ultra rapid onset. Okay, so we're talking about a 12-minute onset with a very short duration, okay, of maybe only a couple hours. And please do stop me along the way if you have questions. Okay, so here's just a brief kind of overview of what kind of the onset of inhaled insulin looks like. So we're talking about onset of about 12, again, about that 12-minute mark, which is faster than our, our Lispros and, Aspart. So that's like 15 to 30 minutes. All our patients talk about how, right? Like I have to like pre-bolus. No one likes pre-bolusing. Its peak is different as well. So you're peaking at like that 35 to 55-minute mark versus, right, your injectables, your sub-Q, you're looking at an hour, hour and a half. Okay. And same thing with how long it works. So your inhaled insulin, it works a much shorter period of time. So definitely less than our 3-hour mark. Whereas depending on what you got on board, Lispro or an Aspart, you're looking at that kind of 3 to 5 hour mark. It kind of lingers a little bit more. And really what it does, because it has such a quick onset, it really reduces that postprandial, that post-meal hyperglycemia that you can get, but also reduces that risk of those like late postprandial low blood sugars. Okay. This is just a chart from, I think I might have pulled it from JAMA. But it really is just kind of highlighting those different insulins, as well as their onsets and their peaks. So this one I like because it also includes FIASP on there. So still its onset is about, still 15 minutes, but it's a little bit faster than say, our Lispros or, like something like Novolog sometimes. Okay. And much quicker than any of the like regular insulins. I really dislike journal articles, but I think it's important to go over just some of the pivotal trial data. That's pretty kind of important here. Okay, so this table really just summarizes the results from the Afrezza with comparators in adults with type 1 and type 2 diabetes. Okay, so it looked at A1C reduction, fasting glucose, and weight change. Okay, and what you see here, we'll go to this part first, is that if you look in our type 1s, what you see is that there was a less for Afrezza, there was a lower reduction in, I'm not saying that right. It resulted in less hemoglobin A1C reduction, but greater fasting plasma glucose reduction and weight loss compared to insulin aspart. Okay, and that's for our type 1s, which I also think is interesting because it's not the exact same thing that we see in the type 2s. So here with our type 2s, you see that Afrezza provided greater A1C and fasting plasma glucose reduction than our placebo and oral agents. And the weight change data, they actually, I'm not too, I can't remember why they didn't get any data on that. But in general, I think it's kind of been reported that when you use inhalable insulin, you in general are going to see less weight gain than if you're doing sub-Q. Questions about that? Okay, and because again, I dislike looking at clinical trial data. We'll talk a little bit about the hypoglycemia data just really briefly. What we see in this data is that it's inhalable insulin is actually associated with a lower incidence of late post-meal hypoglycemia. Okay, so in general, it's there's a lower frequency and severity of low blood sugar compared to sub-Q insulin in type 1s. But in our type 2s, what you see is a higher rate than placebo in our type 2s. Okay. But something to note is that most of the hypoglycemic events that people did experience were not severe. They were pretty mild to moderate, and severe hypoglycemia occurred, or severe events occurred less frequently with the inhaled insulin group than with the sub-Q insulin group. Okay. So who might this be for? And this is where I'm going to get some audience participation. Inhaled insulin is FDA approved for adults with type 1 or type 2 who need some, some help with some insulin when we're eating. Okay. Or if you have, an aversion to injections. Those obviously who have post-meal hyperglycemia, you're like everyone, right? How many of you here, show of hands, have prescribed inhalable insulin, Afrezza? Oh, okay, we'll get to that. Barriers and access. My friend over there, Mr. Parente. Okay, for that one patient. Several patients. Okay, so you can be our expert then and can tell us some other things about it. Has anyone here tried it with someone who's on an insulin pump? No. Yeah. Oh, you have. Attempted. Yes. Yes. Yeah. I'm noticing a pattern here. So yeah, I mean, it's an interesting thought because when I was talking to my endocrinologist trying to coerce her into prescribing me some inhalable insulin, the topic came up. She was just like, I don't really see much benefit to it. And I thought to myself, well, I mean, yeah, it poses some problems with my closed loop because then if I do a little puff of it, right, my pump's not really going to know. So then I'm kind of manipulating my algorithm a little bit weird. Then I thought, well, that's only because I'm in a 780, right? If I was in something like a Tandem, right, I could just like unplug, like have it bolus off my pump. So it kind of knew that maybe there was some insulin on board, right? That seemed like kind of a lot of work though, but maybe. Oh, we got a hand. Uh-huh. Mm-hmm. Mm-hmm. Yep. Yes, yes, for adults. We'll get to our titration. So what's also really cool is the data that's emerging in pediatrics for us. So it's really cool. So at ADA this year, there was a little kind of a little talk, little abstract that got presented about how they looked at in this trial in INHALE-1, it evaluated the safety and efficacy of Afrezza as a replacement for rapid-acting meal insulin in kids with type 1 and type 2. And it was really great because it was a study that was with kids between the ages of 4 and 17 who were using Lantus, some kind of basal insulin. And then they were randomized either into doing the inhalable or sub-Q shots. And what they did is they looked at A1C at the end of 26 weeks, and they found that the inhaled insulin was safe, it was effective, and it kind of demonstrated glycemic control that was comparable to injections. And that's something I forgot to mention in these clinical trials. They're non-inferiority trials, right? So we're saying they're not better. We just have to prove in these trials that it's not worse than doing sub-Q shots, okay? And same thing for this trial with the kiddos. All their data, I think, is being presented a little bit later, possibly in March in Barcelona, Spain at ATTD, which will be fun. Okay, this is actually where there would have been a really cool video of me doing not THC, but this is basically what it looks like, right? It's this cartridge, that white and purple thing. It's a cartridge that you kind of pop open. The white little stick is where the mouth goes. And then you have those cartridges, which I'll talk about in a second, because it made me, when I saw it, I had very immediate thoughts about them. Okay. And dosing, to my friend who said the dosing was really easy. So you kind of open that up, you load it with a cartridge, and then you hold that inhaler on kind of like the purple ends, and well, first you have to like breathe out apparently, and then you breathe in for to get all of the powdered insulin delivered in. And then you kind of exhale normally, and then you have to like peek in the cartridge to see if you did it all. And if not, you have to go again. Okay. For all of you who have prescribed it successfully to patients, what was your biggest kind of complaint that you got? Concern, if any? Coughing. Yes. And then they give some tips for that. They say I think 25% of people have issues coughing. I mean, to be very clear, this would have been a really funny video of me because I can't even do one of the asthma inhalers. Okay, so this would have been extra comical of me trying to do the powder and then bronchospasming and coughing and maybe having some post-tussive emesis or something, but it's right. It's coughing. It's 25%, right? And some of that throat irritation, okay? So I'm really curious to see in this INHALE-1 trial what happened with the children, right? Because this isn't the adults. The adults are the ones who are just right? It's a little problematic. So that's kind of how you use it. You get rid of your cartridge at the end. You have to change out that inhaler every 15 days unless it gets dirty sooner than that. But it all sounds pretty simple, and it's pretty tiny, fits in a bag, a purse, a pocket even, whatnot. How is it dosed? Well, I didn't do a good job of making sure this wasn't blurry. I thought it was just because I put the presentation together without my glasses on, but it turns out it's not. But it comes in very fixed units. Are you right? And this was interesting. So the inhalable dose, it's not like a 1-to-1 for sub-Q. And the smallest unit you can get are these 4-unit cartridges. So that they guesstimate is about up to maybe 4 units. The conversion they use is your 1 unit of inhalable insulin is about 1.5 times, right, an injectable. And so there's a little bit of fuzziness here, which means that you have to pay a little bit of attention to, especially if you're, I would imagine a type 1 or a type 2, what is my blood sugar doing after I ate? Was that enough, or do I need more? Right? And you can do it comes in this little multi-pack that you get of some 4-unit or 8 units, whatever you want to do. as a pediatric provider for our peds people here, what did you think of immediately about the dosing? It's a big dose, right? Like Jess is shaking her head like, no, no, right? Because it means you have to make sure you eat, right? I just told you that, woo, it works fast, real fast. The delivery truck comes, right? It delivers that insulin real nicely to the lungs, gets absorbed real quick. And then my 5-year-old who said they were going to eat the whole sandwich, you're laughing, right? You're just right. You're just like, oh yeah, it's comical, right? Oh, I wanted the 3 pancakes. They don't eat it. They don't eat it, right? So for adults are pretty reliable when it comes to eating. We usually eat a good amount that will cover 4 units, right? But in the pediatric world, right, I saw this and I was like, oh my. Right with it, like right before you eat. Yep. And the other thing that I thought about this, who in here who would like to share that they have type 1 diabetes? Okay, pizza. Let's talk pizza. Right? Everyone kind of giggles too. The ones that don't have it, they're like, oh, we know what that does to everyone's blood sugar. I looked at this and I was like, well, you definitely couldn't eat pizza like on this one, or you'd have to do something like do your puff like well later, right? Because we all talk about like, oh, I bolused, I ate my pizza, and then within an hour I was 40, right? And then I was 320 like an hour later. And it doesn't matter that I have 30 years of diabetes under my belt, I still can't dose for pizza. Okay. So that's what I thought of when I looked at this as well, of like, well, I wonder what this looks like when I'm eating things that might kind of slow down my digestion. Or, right, in thinking about things that slow down my digestion, what about people really who are on something like a tirzepatide or Ozempic who have this delayed gastric emptying, right? Because I told you, I've tried this, right? I played this game too, where I learned that if I was on a GLP-1 and tried to bolus at the time of eating, I have Lumjev in my pump, at the time of eating, it would make me go low. I needed to wait until I was done with eating to prevent that. So I do kind of wonder, right, like how this might play out a little bit more. Okay, here's the other thing, contraindications and cautions. It goes into the lungs, everyone, right? It goes into the lungs. You can't give it to the people with asthma, COPD, or other chronic lung disease. It's a hard no. People who are smoking or with the Mary Jane, sorry, right? Smoking, vaping. You also, before you can start it, again, why I don't have a cool video of me being a fool, is because you have to have spirometry, right? You got to get those PFTs. That's hard. Some people have spirometry. I was at a clinic, one of my continuity clinics as a resident, and we could do spirometry right there in clinic, and it was really cool. That's the only place I've ever seen that, right? So it requires baseline as well as periodic spirometry checks, okay? Reliable eater, right? We talked about that. And you got to be okay with coughing, or hopefully you don't cough a lot, okay? So this is just a little bit of information on kind of lung function. So again, the most common side effect is that coughing, sore throat, or right, low blood sugar. You do baseline, and then you're gonna do, I think it's like every 6 months, it's on my next page. But check out this graph, right? We know, we will guarantee you, that graph basically tells me you're practically guaranteed you're gonna have some decrease in lung function, which happens usually in the biggest jump, I think, or they say most people have it in the first couple months. There isn't long-term data. We don't have long-term data, like more than 2 years out, about what this means. That doesn't exist for us, okay? But we do know that your FEV1 is going to go down, right? A small, but we know it's going to go down. Monitoring, right? So we have to do it, check your spirometry at baseline, repeat that 6 months, and then annually thereafter, right? So you're going to have that arranged. I remember the wait list at UW. That's where my endocrinologist is. And she was like, okay, the next available spot is like 4 months out. And I was like, well, that was the other reason why I couldn't get my inhalable insulin to try. Okay. Monitoring again to make sure that we monitor for any kind of pulmonary adverse effects that a person might have. And I think it's like if we have I want to say it's like a 20% decrease or something like that, there you have to stop. There are like guidelines about when you have to stop if you see too big of a drop in that lung function. Okay. Access, right? I've heard from several of you. One thing for access is that PA. So a lot of insurances put on their list, including Alaska Medicaid, like, yeah, it's on our preferred drug list. It is there. Just requires a PA. Right. Yeah, it's comical, right? And that's what my endocrinologist said the same thing. She's like, it's really, really hard to try and make a case for people to switch from sub-Q insulin to inhaled insulin. Okay, so that is going to be an uphill battle, right? The spirometry access, right, takes a bit of planning if that's something your patient might want to be doing, if you live out in more remote areas, of coming in to be able to access spirometry or CU, and if there's spirometry where at your site, to kind of have that coordinated so it happens at the same time. Okay. There's also, right, the issue of like freezing. So depending on how far out you are and what transport looks like for medication and things like that, you have to make sure that's not going to freeze on you. And then make sure your meds can come to kind of room temperature before you use them. So just in summary, right? Afrezza, it's an ultra rapid acting powdered insulin that's faster than sub-Q, right? It has a comparable A1C to using sub-Q insulin, both in, type 1s and type 2s, but less late postprandial hypoglycemia in general. It's FDA approved in adults without underlying lung conditions or issues. Make sure you screen for your contraindications, right? That baseline spirometry, and then 6 months, then annually thereafter. And that's about it. What questions? Any more questions, comments, experiences that anyone has?
You know if like severe needle phobia counts on the PAs?
Yeah, you can definitely use a needle phobia. And what I'll say is that it depends on if you have a type 1 or type 2. When I think of it logistically, because I thought about using it for a kiddo that I had with she was 17 and she had a severe needle phobia where she had another condition which caused her, she needed to get she had to get at labs, okay, that were blood draws. She had to go to the anesthesia clinic at Seattle Children's to get sedated to get those labs. And that's how we found out she had diabetes on one of these labs, which then became very interesting for us because you need at least one right? I need my basal insulin at least. Okay, so yeah, I could do inhalable insulin, but I still needed some basal on board for her. I mean, even trying to get a CGM on this kiddo, there was like screaming down the hallway. I mean, it was, at the end of the day, you know, she wanted to treat her diabetes, but it was very, very hard. And so her mom, they'd come up with a plan basically where her mom would like literally pin her down and another adult would put on the CGM, or we use that kind of like, I want to call it a port, but it's not a port, the one that stays every 3 days and then you can inject into there. And that's what we ended up doing because she could then use the needle and use the port on her own, which is kind of great. But it was that initial poke that was really, really hard. So yes, needle phobia, you can definitely, it's probably your best bet, right? Is saying they have a needle phobia and we can't do that.
I assume you have to worry about stacking the same way you do about injectables.
Yeah, but you remember you have that duration, like it's lasting a lot shorter. Yeah, which is nice. And my friends that actually use it, so I know a couple type 1s who use it, they kind of love it because they also aren't huge fans of having to wear as many devices. So they're just like, I like doing a shot at home once a day, my Lantus, and then taking my with me around. And then it just like comes right down. They're just like, it's lovely. And you look at their CGM and it just, you know, it looks great. So yes, you know, there's that.
Yeah, so a couple things on this this medication. You can send a prescription to your pharmacy. They can order it. They can't. If you talk to the company themselves, they actually supply it out of Sterling Pharmacy in Minnesota.
Mhm.
So if you type in Sterling Specialty Pharmacy, it has to say specialty. I couldn't find it for a while, and then I typed that in and I found it. They're out of Minnesota. They supply it. Whatever route you can get it through, though, it's still going to be a PA. If you're thinking about prescribing this, I would recommend that you put your patient on injectable rapid acting insulin first, because all the PAs are going to ask if they've done that, and if they have not, they're going to require them to do that, and it's actually really hard to get this covered. So I would recommend you do that and do it for at least a month. Document it. One good thing about this one that I've had, so I have patients that have jobs that they're on the go constantly, they're on the road. This is a really good option for them because it's much more, it's easier to carry than a pen. They don't have to clean the site and step away and, you know, lift their shirts. A lot of patients are self-conscious about doing stuff like that because they quote unquote say that they're overdosing in front of the public or whatever they want to call that. So it's easy for them just to take a tube. It's very covert. You just do it, take a quick puff of it, and they're done. The good thing about this one too is because it's so rapid acting, you actually do this with your first bite. So that's when you do it, as opposed to having to do. It is like I've been told it's like within a 10-minute onset. I usually just tell people do it the first bite. That's what the company is going to tell them to do. And I've had good success. I have some patients actually that are doing pretty good on it. The issue I'm running with is supply and coverage. So even if you get the coverage, the supply, I was just telling my colleague here, of a patient who, so you saw the supply formulation on that slide. They come in different like combinations. But if you have a patient that needs 8s and 12s cartridges, because sometimes they'll take 8, sometimes they'll take 12, and then you can combine them however. Pharmacy, insurance companies, they will never, they'll probably, they almost never want, they'll never give you what you need. So you have to, oh yeah, that's no surprise for anything, but that one's really tough though with this one. So these are just a few things that I'm just telling you that if you're thinking about using, just keep in mind. So if you have any questions about it, just let me know. I've used it for a few people. It works pretty good though. When everything does fall into place, it works really well.
Thanks, Mr. Parente. Also, you know, when you said like, you know, oh, they have to clean their site, I kind of was just like, who cleans their site? No, laughs. Yes, right over the shirt.
Yes. So I was told by a Mankind rep or the company behind Afrezza that they will supply your clinic with like a spirometry type of device that they
Oh,
will
yes.
supply it for free. So that could help with the barrier of the pulmonary function test.
Yeah, I forgot to point that out. Yes, I had actually asked for one, but because I don't treat people over the age of 18, I couldn't get one. I was just like, oh, can I think of at least one? So yes. Oh, okay. Cost is good. So, if you were here last year, I gave a talk about teplizumab and I talked about how expensive it was out of pocket. I decided not to look at that because the the company actually ends up having, like most big pharmaceuticals with really pricey drugs, they have a copay assistance program, so that can bring down a copay to like $35. Yeah, to $35 a month. So that makes it very affordable for most people when they're able to get it approved. And I think on their website, they do talk about even if you don't have like coverage, they might be able to supply it for like $99 a month or something. So nothing insane. And like I said, Medicaid here apparently listed as on their formulary.
So I had a patient who was on Medicare. We tried to get it for. They didn't cover it, but she went to go attempt to pick it up and it was $1,200 for a month.
Yeah.
And that was for the 4-unit cartridges
How much was it?
at $1,200.
Rachel? Yeah, there's that. Right. Anything else? Yeah.
I noticed the different doses were in colors. Do they have like another way to tell the difference
There's a
for
number.
people who are colorblind?
Oh, there's a number on it. So it's like 4, 8, and 12.
Thanks.
Yeah. Strong, Rachel, strong. We have a runner for you, very kind runner.
I remember when they first got it approved and the initial FDA trial, there were a couple people died of cancer and they said that that wasn't higher than the usual rate of dying from cancer. But I wondered if there were any post-marketing studies and that kind of thing. It sounded scary to me.
Yeah, I haven't seen there's not any kind of data, like long-term data past those 2 years that they were followed that I know of.